Hello and welcome to another episode of Walking with Walfinch. Today we are not at Hampstead Heath. We're joined by Lucy Pollock with a beautiful backdrop of Alfred's Tower out in Somerset. Who are you, Lucy Pollock, and why are you here?
Amrit. Okay, my name is Lucy Pollock. I am a geriatrician. I work in hospital medicine, which I've done for a long time, obviously. And I have written a couple of books about older people and their families and the challenges that can face people as they get older and the things that we need to celebrate. But most of the time, I'm basically a consultant geriatrician, and I have a very nice time working with older people, with young doctors, with a huge multidisciplinary team of social workers and healthcare assistants and fabulous nurses and discharge liaison people and therapists and all the people that, help look after older people.
That is just phenomenal. You are very much our people.
That's good to hear,
So,
yes.
I'd like to tell you how I came across you, if I may.
Yes.
So I'm there having a very fast read of the Sunday Times because I've got, as I was saying before, that I've got 3 children. So where you get your 15-minute blocks
Yes.
of an espresso and a crack at the paper. Here we go. And there's this book that's there called The Golden Rule by Dr. Lucy Pollock. And I was like, what? Nobody writes about this.
Yes.
Right?
Yes.
And so I take a photo because obviously I don't have enough time to continue there and deal with the kids, come back to it, order the book on Amazon, read this book, and I was just gobsmacked.
Oh.
It was a phenomenal read. Brought it with me today to get signed. So, it's...
Well, you are making me very happy. I'm really glad you liked it.
It was just amazing. I've spoken to people about it. And then I had our team saying, "Oh, look, gosh, she's very cool, and we need to get her on." But 7-8 months have gone past, and we've been trying to do this.
Busy lives,
just,
busy lives. Amrit.
Thank you very much for being on.
No, it's really nice to be here. I'm delighted because your world is fascinating. Your Walfinch is working with older people in many, many different places in their own homes, doing, by all accounts, a phenomenal job. And we need to really work out how to capture what you're doing and to keep going with it and to make it work for lots of people because, as we know, the demand is growing and growing, isn't it? And the need for really high quality care is there already and is growing very rapidly. So it's great. I'm really glad you like that book. When I wrote it, I had no idea what I was writing because I'd written the first book, which is the book about getting older, and that was an easy one to write because I'd wanted to write it for about 25 years because I really wanted to answer lots of questions for older people, like, should I be for resus and should I be taking 11 different medicines, and what do I do if my dad shouldn't be driving and he's not going to listen to me, actually some of the really tender ones, are you allowed to love somebody and wish they would die, which you are, but nobody ever talks about it. So, how do we deal with people coming towards the end of their life and respect their wishes and so on. So that was an easy one to write. But the second one, the publisher asked me to write it, and I thought, I've got no idea what I'm writing. And even while I was writing it, I thought, this is a complete dog's dinner. And then it came out, and I was so lucky because it did get very nice reviews. So I was delighted about that.
My take on it as a reader was that it was somewhere as a cross between memoirs and this beautiful text about caring for people. Just the kindness, the tenderness in it was really wonderful.
I hope it's a bit of a manifesto because I think it is very easy in this complicated, pressurised world to lose sight of the fact that at the root of all of what we're doing are human beings with emotions and feelings, and really trying to make sure in the future that, we've got this incredibly exciting future with a whole load of AI coming down the track. And what we've got to do is work out how we maintain the human aspect of care and medicine in older age and so on. So that, I think, we're at a really important point now where we need to work out that little interface between the incredible technology that we need to harness and the what it means to be human, which is what this is all about. So,
It's really interesting and really kind of going straight back to the beginning, geriatric care. I mean, it's not the sexiest topic, and frankly, there's not loads of doctors running to do it.
Well, do you know, that's changed actually. So people say, you know, why are you a geriatrician? Isn't it depressing? You know, I wouldn't want to do that. Actually, of course, it's an incredibly rewarding career. But I didn't want to be a geriatrician when I was a young doctor. I had all sorts of other ideas and I liked lots of different specialties. And then this really good older physician said to me, he said, I hope you won't be offended, Lucy, but I think you should be a geriatrician. And the minute he said that, I thought, you're so right. I know that's what I need to be. Because actually, it's fascinating. So it's intellectually really stimulating. It's really complicated. None of my patients have one problem. They've got 8, 9 different problems. So medically, it's fascinating. And then you work with amazing teams. So you're working with lots of good people. That's good fun. And then, of course, your patients are just the rest of us grown up with good stories, you know, so you're learning all the time from this fabulous group of people and their families, and families are fascinating, you know. If you're interested in human beings, you know, geriatric medicine could not be a more interesting subject. So and you can make an enormous difference.
Yeah.
So it's enormously rewarding. So actually, the really interesting thing is now, I watch very young doctors coming into geriatric medicine, and it's a popular specialty, and
Is it really?
It is now the biggest specialty in the UK. It's just got ahead of the cardiologists.
Wow!
And it is attracting some of the brightest and best. So I am
That's amazing.
and that's changed in the course of my career, and I love watching that. It's a specialty that's flourishing. So really happy about that.
Gosh, and so what does it mean to be a geriatric specialist?
You do a long training, so you do your 5 or 6 years of medical school, and then you do your 2 or 3 years of being a young doctor doing lots of different things, and then you might get a registrar training post, and that's going to take you another 5 years. So, and during that time, you will train in lots of different things. You'll train in the care of people with hip fractures, you'll train in the care of people with strokes, you'll train in community geriatric medicine, a really good growing field. You might train in acute frailty, which is really what a lot of my work is. So people who are suddenly unwell come into hospital. How can we make sure that we look after them well, turn them around, get them home? So it's very varied, and people end up doing lots of different subspecialties within it. And for me, it's mostly now ward-based, and then there's a huge training aspect. So on a ward round on a Monday that I do with my lovely colleague Vicky, we have with us often a registrar, we have 2 or 3 or 4 young doctors, we have a doctor on a clinical attachment who's kind of finding their feet in the NHS, we have 3 Bristol medical students, maybe a couple of Peninsula medical students, we might have a physician associate student, and on a Monday morning, as Vicky says, we've got the children because we get 2 sixth formers on work placement. Jeepers, we are very busy, but they are all, I hope they're all learning. It's a real juggling act, and then you've got a patient that you're thinking, okay, let's get this right. So it's it's a busy place.
That's phenomenal.
Yeah.
So Lucy, this could end up being a 5-hour podcast. I've got so many questions for you.
Yeah.
But you know, let's start with the average older person that comes in.
Yeah.
You know, what is the issue that person has?
Okay.
And how old are they?
Okay.
And who are we talking to?
Good question. So who are my Monday morning patients? They are mostly people in their 80s or 90s, some centenarians, some a bit younger but with complex problems. Because they've come to the acute frailty unit, they have been selected because they have got some complexity behind them. So they might be somebody from a care home, but more often they're somebody who's living at home, maybe independent at home, but has hit a bump with falling, or has got pneumonia, or some sudden acute medical problem, or is living at home with quite a big package of care and is pretty fragile and may have been in hospital several times before, and has got a very long list of medical problems and usually a pretty thorny patch of medication to sort out as well. So there's a lot going on, and on each ward round I have to gather a lot of information very quickly, which is a real challenge in the NHS. In our hospital, I have to open, brace yourself, 8 different systems for each patient.
8 systems?
It is shocking how bad our IT is. It's disgraceful. Now, we do have a project to change that in Somerset and Dorset, and there is a new one coming out, but it's not going to be for the next few years. And meanwhile, I have to open a separate system for blood results, x-rays, the GP notes, our community hospital notes. Hello, lovely dogs. Hi. And for our own notes, for our discharge summaries. I mean, it's insane. And then you walk
It's a
away.
full-time job within
Well,
itself.
it's just in terms of productivity, it's a really shocking waste. And, you know, I then walk away to talk to the patient, and when I come back, I'll have been logged out of all of those, and I have to log back into them all. So that is, if I could wave a magic wand and change one thing, jeepers, that would be probably it.
I imagine, yeah.
But anyway, once we got over the frustration of the IT, the rest of it sort of falls into place. And then we are planning really, usually, how to get that patient turned around better, well. A lot of deprescribing, a lot of conversations with our patients about what their medicines are, what has meaning, what's doing them good, what's doing them harm, what's worth taking.
Yeah. Well, that's an interesting thing,
yes.
isn't it? Because often there's things prescribed en masse
Yes.
because it's easy and it ticks a box, but is it worth it?
Yes, I had a lovely conversation last night actually with a fabulous group in Scotland. It's the Realistic Medicine campaign, which has been going for a decade now. We all learn to prescribe, and we're not taught, we learn how to start medicines and we're not taught how to stop them, when to stop them. And that's a really important thing for older people. So we know that at least 1 in 10 and maybe 1 in 5 emergency medical admissions in older people is due to a problem with their medication.
Yeah.
That's insane. If you said that about surgery, if you said 1 in 5 surgical admissions was because of not very good practice by the previous surgeon, you'd be all over the newspapers. So we've allowed this to happen with prescribing, and it's a real challenge. And it's not because people are, you know, slapdash. It is because prescribing is really complicated now. And again, to get that right, what we need is very good training. We need to embed training really from the outset. We need better science about what works and what doesn't work for older people. And then we need time. And then we need to get the AI to really support us to spot the problems in the drug chart, to challenge everything.
Well, because presumably you're fixing something over here on their blood pressure, let's say, with one medication.
Yep.
But then that has a knock-on impact on something else.
Exactly. Their blood pressure drops too low. Really common problem in older people. They've got a high blood pressure when they're sitting or lying down, and when they stand up, it drops into their boots. That's really common postural hypotension, aggravated by medication. And actually, lots of people don't know that actually your blood pressure does not go on going up as you get older. It starts going down about 14 years before you die. And we need to reduce people's medicine. So that's common. And then the other thing is about older people themselves and their medicine. You know, what control do they have? What do they understand about it? What can they do for themselves so that they feel at ease with what they're taking? And then in your world, what can carers do about medicines? So a lovely project in Somerset, which is, I hope, going to be rolled out nationally, was done by Deb Gompertz, a complex care GP, and her team. And there they used unqualified people, carers who didn't have any background in pharmacology or drugs, but simply to say to each person they were looking after, could you please show me your medicines?
Right.
And the minute you look at them, you often know whether there's a problem. Are they in a gold casket with a laminated sheet saying what everything is for and when I'm going to take it, in which case things are probably fine? Or are they in 3 old Tesco bags down the back of the city and one in the kitchen and one that's got the dog's medicine in with it? And
sounds like how my medication would look.
Yeah, exactly. We all know it, but you know, you can so easily spot that there's a problem. And just having that gentle conversation saying, gosh, that's a lot of medicines. Do you struggle to take them all? Yes. And then you find that 1 in 4 people are not taking the medicines their GP thinks they're taking. The waste is absolutely staggering, as well as the harm. So we've got a kind of moral duty to sort that one out. And there is a lot of work going on to improve things on that one.
So that's okay. So we are in a situation here now where, to surmise, you know, we've got the demographic of the person that we have coming into the hospital and that we're providing care for. Then we are in a situation where we're sort of saying, well, okay, there's an issue in the way that we are prescribing medication. And there are things that need to be done to consolidate
Yes.
the way that we're prescribing,
Yeah, yeah,
and it
yeah.
needs to be. Should we?
Oh
Let's go
yes, we
down
can
there.
go down this way. Yeah.
And it needs to be thought about in a very different way, and probably we need the support of AI. You're saying actually
Yes. Very
because
much
it's so
so. Yep.
complicated.
Yep.
And you know, you think about an older person with 11 different
Yeah.
medications, 5 different conditions that
Yes.
they've got,
Yep.
which are moving on a regular basis.
Yep.
And also, you know, in my mind, I'm thinking, well, there's a district nurse involved, there's a doctor involved, there's a GP involved, there's a care provider involved, and so on.
Yes.
And all of these people hold different bits of information,
Yes. Yes.
which they don't necessarily.
Join up.
And
Yeah.
so, and actually, if you had a centralized piece of equipment, an
Yes.
AI, a software,
Yeah.
or something, I mean, that would be really interesting.
I think that it certainly has a role. It has an important role. And there are prescribing systems. The difficulty is they often pick up lots of very unimportant drug interactions, for example. So they put up loads of alerts and say, oh, have you noticed this?
Yeah.
And actually they're irrelevant. And you eventually get alert blindness because
Yeah.
it's throwing so much stuff at you that isn't important, that it then does miss some of the important stuff. So we need to train our prescribing systems to work better. But actually, what really matters for older people is a personalised understanding of what their goals and wishes are, because you mentioned they might have a GP and a specialist. They're often seeing multiple specialists. They've got multiple conditions. And if you keep prescribing for each condition separately, you will inevitably end up with an awful lot of medicines. What lots of my patients need is we use a framework called BRAN. It's really nice. You need to go through every drug on the chart, and I say you're going to look at that chart with a tooth comb, and everything has to earn its place. And the BRAN system says, okay, what is the benefit? What are the risks? What are the alternatives? What happens if I do nothing? And a patient can ask that, or a carer, or a family member, but doctors need to ask it of themselves. And we need to challenge ourselves when we say, oh, there's a benefit, oh, take your aspirin to prevent you having a stroke. Hang on a moment. How much benefit is there? Is it really going to prevent a stroke? No, it's not. It's going to marginally change the risk. So there's the words that we use, oh, take this because it's going to stop you having a heart attack. No, it's not. So we use bad words, and we need to sort that out. And then for every patient, you need to then assess, right, is this medicine worth taking? And this is not about the worth of the patient. The key thing is, this isn't about whether that person's life has value. It's whether the medication or the treatment or the investigation or the operation has value. Is this the right thing to be doing? So and those are really nuanced, Amrit. So those are, really individual conversations about, whether you like medicines, whether you're worried about the bruises on your arm from your blood thinner, or whether you've never wanted to take that particular tablet because it's pink, or whether you don't want to stop this medicine because you've been on it for ages and you really trust it and your doctor is saying it's got side effects, but actually you really like it. So these are very important to get right. And the way to make the complex situation simple is to absolutely start every time with the patient at the centre. What are their goals? What are their wishes? What are they trying to achieve? And then you build the prescribing around that. But it's it's a theme all the time for us.
I think that's really interesting. I remember reading this in your book, and you were talking about putting the person at the centre of the conversation and really saying, well, actually, what matters to them first.
Yes, yeah.
And, in social care, we talk about this a lot, person-centred care
Yeah.
and so on. But actually, we never question it from the doctors. And
No.
we just assume that, well, if that's a medication, then we can't question that. And that doesn't come into the person-centred
And
piece.
I would love carers to be a bit strengthened on this one. Carers are often aware that Rose doesn't like taking her medicines. They have to coax her to take them every day. And the carers often feel under real pressure. They think if she doesn't take that medicine, she's going to get sick. Actually, that's not true for most medicines. And actually, if a carer's in a situation where somebody's having a miserable time and is not enjoying their medicines, I think they should be able to say, please can we have what's called a structured medication review. She's not liking them. You know, she's spending half an hour trying to get her medicines down at breakfast. I'd rather she ate her porridge with golden syrup.
Yeah.
Okay, let's ask the doctor. So I think we should shore up carers to be part of that conversation and to advocate for their patients.
I totally agree, because you know, I don't like taking pills,
No,
for example.
no,
And my wife
none of
always
us
laughs
do.
at me,
Yes.
because you know, even the big omega-3 tablets
Yes,
that I
yeah.
take, you know, they always get stuck in my throat, and she always giggles when I'm
Yes,
taking them.
yeah.
But you know,
Oh,
and
do you know, I'll give you a handy hint. I've been a doctor for about how many years? More years than we like to count. And I didn't know this, but when you have got big tablets and you struggle to take them, here's the trick. You put it in your mouth, you take a sip of water, put your head on one side, swallow, and it goes straight down.
Is that
Oh my
right?
God, it's a game changer. I wish somebody had told me that a long time ago.
Lucy, you may
One
have changed
side
my
or
life.
the other, doesn't matter, it'll go straight
So you
down.
can giggle at something different now. So you know, so
Crazy.
I think when I think about that, and I think
Yeah.
about older people, and I think about actually care provision on the
Yes,
ground.
yeah,
Now, the worry that as a provider you have is, if somebody hasn't taken medication, there's a whole big thing about this.
Yes.
You know, there's a safeguarding, there's a medication assessment, and
Yes,
so on.
yeah.
And it may have been a paracetamol, you know,
Yes,
frankly.
yes.
But we make such a tremendous deal out of this.
Do you know, and I've suddenly clicked something, because I talk about the amount of time that our patients are having to spend worrying about their medicines and taking their medicines, but actually for carers,
Yeah.
it must take up so much of their time
Absolutely.
as well. So actually, we need to think about, is this tablet worth the carer being anxious about? And that's really important. Do you know, I'd never factored that in, and you've really made me think now, because is it worth their time and their worry and so on, or should they be told, do you know, it doesn't really matter if she doesn't take that one?
Well, when you think about care workers leaving the sector,
Yeah.
you know, this is one of the reasons, the pressure that we put
They're
them
so
under.
worried about medication.
Yeah.
Yes,
You know,
I
and
agree.
they're thinking, well, oh gosh,
Yeah.
this is a legal matter now, actually.
Yes, and nurses worry as well, and they think they're going to lose their PIN if they make a medication error or don't get it in on time or whatever. Yeah, really important. I mean, there are important medicines, and nobody should just stop them without talking to their doctor, and no carer should just say, oh, look, don't bother with those ones, Rose. Obviously, you do need the advice, but what you are entitled to is a good conversation
So a
with
structured
someone,
medication review.
with a
So,
pharmacist or a doctor.
and so if you were giving a message right now on this matter to care workers and care providers, what would that message be? How do we cascade this message down to them?
Okay.
What do they need to do?
I think what I would suggest is, we'll just let these lovely guys come past. So what would I suggest about medication? I would say, carers, remember that you are an advocate for your client and that you can advocate for them. And if you're concerned about someone's medicines, if you feel that they're struggling with them or not enjoying taking them, or they seem to be having side effects, feel empowered to highlight that to someone who can do something about it. I think it's a completely legitimate part of being a carer, and you've got an absolute right to do that.
No, that is wonderful. And, you know, through the Walfinch network, certainly we'll be really hammering this message home, because I think
Good.
about this, and I think, you know, what is beneficial for the end user. We talk about aging as a thriving,
Yes.
you know, and not the final chapter.
Yes.
And I think that this all encompasses that. You know, if I was in that situation myself, you know, I'd be very prescriptive as to what I want and don't want. You know, and it's my choice as to, well, I don't want to take the medication around blood pressure because it makes me vomit or whatever it is.
Yes,
you know,
or feel dizzy
choice.
and unsteady.
You know, but I don't feel like as a sector we empower clients enough to say no. Actually, on medication. And I think that it's an interesting thing because there's so much fear around it. But I think
so.
having structured conversations with clinicians is really important. One of the most useful meetings I've ever had has been a multidisciplinary meeting around a particularly difficult client years ago.
Right.
And this was in Oxfordshire, and there was me, the mental health team, the GP, the district, you know, we were all met in one of the hospitals one of the buildings off the Churchill Hospital in Oxford, and we sorted it out. You know, we looked at the medication, we looked at how the care was being provided, we looked at, you know, where the sort of social workers that work on coaching from a mental health perspective were coming in, and how the family was involved, and, you know, in fact the family was there. And it was just so powerful. Now, I also appreciate that that is time consuming for everyone and there's budget issues, but actually, by doing that, care was significantly
Yeah,
better and everyone
exactly.
was much less
Yeah.
involved for the next 6 months.
And I think this is one of the issues, isn't it, when people are so under pressure, but one has to regard these things as an investment,
Yeah.
and that they will pay off. So this is where we have to build in the time to get this kind of conversation right. So yeah, I'm completely with you on that. So that is a good subject.
That's wonderful. So, Lucy, the other thing I was thinking on the train here this morning, and it was a really enjoyable train, I must say. I was looking out the window at the beautiful Greenland in England. It
Yes,
was
yeah,
gorgeous, actually. And then I was really thinking, if you were in power,
yes.
how would you change the way that we get funding in social care?
Okay, this is a really big issue, isn't it? And it's been kicked down the road for so long. And, successive governments have said they're going to engage with it and then
Yeah.
they don't, because they can see that it's politically poisonous and it's going to be an electoral disaster if they challenge the status quo. But we have absolutely got to change this. So, the Dilnot report that came out in 2012, I think, was welcomed by the government. Then they looked at it and thought, oh no, it feels a bit uncomfortable,
feels a bit prickly.
not going to do that. So, and it means that we are wasting people's time. Lots of my patients, to be honest, are in their last year of life. Not all of them, but a lot of them are. But patients particularly who've been very unwell and in hospital. And every day is precious, and wasting it, sitting in a hospital bed, waiting while there's a colossal argument about the funding of care is insane. It's also very destabilising for the care sector as well. And I really respect care homes. They get a bad rap, but actually the care homes that I know and love are places of love. They are people's own homes. They are many of them are run incredibly professionally, and they are good people. And it's so unfair that everything comes down to whether the last penny of money can be squeezed out. So we have got to grip that. It's making older people very anxious and unhappy. It's making their families anxious and unhappy. And we could do it so much better. So I think that we have to move to some kind of probably insurance-based system for care in later life, because it's such a lottery whether you're going to need it as well. I say it's a lottery. It isn't entirely a lottery, because we do also know that disability in later life and impairment in later life is so related to your lifestyle when you're younger, and a lot of that is related to socioeconomic things. So in the end, a lot of this does come down to improving people's opportunities and education in younger life. And it's really sad that people in the lowest socioeconomic group have not only the lowest life expectancy, but also the highest proportion of that time spent with disabilities. And that's clearly very wrong. Chris Whitty's fantastic 2023 report about the ageing population highlights that point. So lots of the conversation we've got to sort the funding out, make it equitable, make it fair, and make it available. And recognise that this is a thriving economic industry. People in later life spending their money on care is a very good thing for the economy. It gives people loads of jobs. It moves money from being locked up in the savings accounts of very old people who are never going to need it to an income for a young carer with a family.
I mean, it's that transfer of wealth, actually, but
It's
in a really better distribution.
Let's celebrate that. Spending money on care later in life is not necessarily a bad thing.
That's a wonderful way to look at it,
So,
actually.
yes, I mean, if you need it, you need it.
Yeah.
But then in parallel with that, we can do the work that actually allows people not to need care, just to try and defer some of the things that cause people to lose independence later in life. So, and there the work is starting at the very beginning. Starting before people are even born. What I always say is, in the old days, there's a sort of curve of life. So you've got independence up the side and you've got age along the bottom on a kind of graph. And what you want to be is you get to be 100% independent while you're a teenager or whatever. You learn everything you need to learn. And what we all want to be is alive and well, alive and well, alive and well, dead. That's the kind of plan.
That's the ideal.
But what happens, of course, now is increasingly people are alive and well, and then something happens. They have a fall, a fracture, another a hip fracture, a stroke, an MI, terrible arthritis, that's very frustrating. Obesity increasingly is a problem. Dementia is the big one. And you get this curve at the end of life of increasing frailty and increasing need. And really most people, a lot of my patients are in the bottom corner there, where they are very old and they also have got quite a lot of disability and are very dependent. And that we have to be careful about that, because not only we make misjudgments about people's quality of life down in that bottom corner of this graph. Actually, lots of older people who are very dependent still would value their lives and have a very good quality of life. And when you're a younger person, you could say, oh, I wouldn't want to be living in a one-bedroom flat with carers coming in, and that's not the life I'd want to be living. It sounds miserable. Actually, if you ask that person, they say, I'm very happy. I love this life, and I like my carers, and I like my cat, and I'm completely contented. So we must be very careful not to misjudge it. But at the same time, most people, not everybody is happy. Some people are having a very difficult time, and most people would much rather avoid that if they can. So what else do? We make sure that people are born well, that you don't have fetal alcohol syndrome when you're born, that your mum has been taking some folic acid before you were born, so that you don't get born with some neural tube defect or something that really makes your life much more difficult from the start. And then what we need to do is make sure that you build up the good behaviours in younger life, like playing netball when you're in your teens to strengthen your hips, because that's going to make more difference than any osteoporosis medicine to how strong your hips are in later life, and avoiding a fracture. And then in midlife, all the stuff about good diet, just sensible. It's not about supplements, and it's not about how many raspberries you eat. It's just really basic, good information about eating a reasonably healthy diet, eat your greens, don't smoke, try to drink in moderation, take some exercise, and have some social connections. All of those key things. This is a rather boring message. Nobody wants to hear that. But
I was going to say, the social connections and the booze kind of go hand in hand.
Yeah, well, they certainly do in Britain. We have a very alcohol-fueled social life. But actually, of course, we're recognising more and more that might not be a good idea.
I feel like the Gen Zs are sort of sorting that out.
God, they are teetotal, aren't they? Jeepers. Yeah, I know. Yeah, come on, there's a bit of balance to be had, guys. So getting all of that right, and then so how do we defer that frailty curve? How do we all do as well as we can going into our later years, and we can make big differences to that. For so many older people, and for lots of my patients, the key movement to be able to do is not run a marathon in your Lycra and your trainers. That's great if you can do it, but really the key movement is being able to do this. Go from a sitting to standing, because that is the one that allows you to maintain your independence at home. And it seems such a little thing, but if we can help older people to maintain muscle mass enough to be able to do that, that is a game changer. And
what about sort of someone in their 80s? Can they still continue to develop muscle mass?
Yes, and I think that's a message that people don't realise. There is a natural loss of muscle mass in later life. It's called sarcopenia, and people do lose muscle mass later in life. But you can slow that process down by maintaining exercise, usually with a bit of strengthening exercises involved in there as well. And you can rebuild muscle. And we see that all the time. I see it in patients who've had a hip fracture, for example, and become very deconditioned, in bed for a little while, or been very unwell for some reason. That is what rehab does. When you get somebody into a good rehab unit, or back at home with some exercises and some good following a physiotherapy program, being encouraged by a carer to get moving again, every single day, you're watching muscle grow. So people don't realise that in your 80s and 90s, you can still recover muscle mass. That's really important.
So this really gets me thinking about people at 3 different stages. If I think about my own life, and I think about my parents who are, my mum is 70, father is 75.
Right.
My mum has sort of dodgy knees and refuses to get a knee replacement. Separate discussion. But is active. She walks a lot, and one of the things I often say to her is just get a chair and just sit down, stand up, and do that, 10 sets of whatever it is.
That's good advice. Yeah.
Now, but they both exercise. My dad does his Joe Wicks and lifts
Yeah,
some weights
brilliant,
and so on.
brilliant.
Now, for them, what would your advice be? You know,
Yeah.
in terms of diet, in terms of exercise, you know, what are the kind of your 5 hacks there?
Okay, what would I say? I would say first, enjoy life. You know,
Yes.
you've reached retirement age, you've got fantastic grandchildren. Enjoy every minute of it. That's the first thing. So, you know, never make it a guilty thing that you've got to do this or that. If you are able to take some exercise, you know, just being active, do something that you love doing, be proud of it. When you've finished your little exercise program, whatever it is, or big exercise program, be proud, say, go me, really celebrate the fact that you're doing that, and try not to stop if you can possibly help it. So that would be an important one. In your 70s, I think, be mindful of the fact that your body does need a bit of looking after. You can't make assumptions about it, so be respectful of it. So be a little bit careful when you're doing weights and things like that, that you're not overstraining things. So if it hurts, stop. But a bit of muscle stiffness the next day is great. That shows you worked hard. So be proud of that. In terms of sort of lifestyle changes, I think in your 70s, it's interesting. For my patients in their 90s, I tend to say, oh, for goodness sake, you know, have whatever you like.
Please crack
You
on.
know,
Here's a cigar.
yes, exactly. You've done very, I don't tell 90-year-olds to stop smoking. If you're in your 70s, I think, in fact, I don't tell anybody to stop smoking. I might give somebody with some advice, but you know, let's be realistic. But in your 70s, I think, you know, you do want to enjoy what you're eating, but if you can make some tweaks to it, which means that you are making sure that you know, do eat your greens bit, that's good news. And then I think being a little bit respectful about whether you do need medication or not. If you're prescribed something, you ask those BRAN questions. Okay, what is this going to do for me? What's the benefit? Is there a downside? What's the risk? Is there an alternative that I could do instead? I mean, as a good example is older women often have problems with continence. That's very common. It's not normal, but it is very common. And they end up being prescribed these medications for overactive bladder. Now, we know now that they are associated with a 10 to 20% increased risk of dementia. And that's not widely known. And these are what are called anticholinergic drugs. Now, we don't know that that it's causative, but it looks likely to be causative because acetylcholine, the little neurotransmitter that they're blocking in the bladder, is actually a key neurotransmitter in the brain. We treat dementia with cholinesterase inhibitors designed to increase the amount of acetylcholine. So there's a plausible mechanism for that. And that's a real worry. I think, would I want to take a tablet in my 70s that works for 1 in 9 people and has a 10 to 20% increased association with dementia? I think not.
Sounds like pretty bad odds.
It does. And an awful lot of people haven't been given advice about what the alternatives are. If you do have that problem with overactive bladder that kind of gets you caught short, is watch out about alcohol. Cut caffeine out completely from your diet. You know, just change the whole lot to decaf. Be careful about some of the more acidic fruit drinks that can be a little bit aggravating for that. Do your pelvic floor exercises, because although it isn't necessarily a primary pelvic floor problem, having a strong pelvic floor helps you with that. And then seek some advice about bladder retraining. And I would do any of those before going down the route of taking one of those medicines. So, you know, that's a really good A in the BRAN one of benefit risk alternative. There are good alternatives. What happens if I do nothing? So I'd do that for any medication. And then this thing about social contact is so interesting, isn't it? Because we know that literally loneliness kills, and it does it for young people is very bad for young people as well. And therefore, having a sense of purpose, having people that you like to meet, joining a group, making new friends, that's absolute gold dust for older people.
That's really, really lovely to hear. I mean, there's a few pieces there. One, I remember in your book, The Golden Rule,
Yes.
one of your notes to your 18-year-old self was, for goodness sakes, do your pelvic floor exercises, which I thought made me chuckle. But and so I think that's really, really interesting. And I think the other kind of part there is think about things that we're up to at Walfinch. So
Yeah.
one of the things, as we rebranded, because I didn't resonate with how care was being prescribed, how it was branded within
okay.
the UK.
Yeah.
I sort of felt like it hadn't changed in the last 20, 25 years.
Yeah.
And you know, if I think about my own life, I'm very active, and you know,
Yeah.
hence the walking podcast.
Yeah,
and
yeah.
you know, I think about my parents who are very active, and touch wood that continues for long may it continue. And
Yeah.
you know, I sort of think about that, and I think, well, my initial thought was, in 15, 20 years time, if they require care, do they want this, or do they want something else? And I really couldn't see them buying that.
Yeah.
And so we went through this whole journey, where we now look at aging and longevity within
Yeah.
home care.
Yep.
And we're talking about this kind of concept of thriving, but we're like,
Yeah.
well, how do we make that come to life? Yes, things like this, you know, information out there, podcasts
Yeah.
and so on. But you know, we do Thrive clubs, which are community clubs, and I'm the brand ambassador for the Royal Osteoporosis Society.
Brilliant.
And so we're
Yeah.
you know, donating to them through these Thrive clubs, and
Yeah.
these are community clubs around the country that our franchisees put on,
Yeah.
free of charge for older people within
Yeah.
the community,
Right.
their clients and others,
Yep.
where they can do an art class, they can do some yoga or whatever it might be, chair exercises.
Fantastic. Yeah.
And so we're hitting two different things there: exercise, muscle mass, but also
And
that community.
Community. Absolutely.
And
Yeah.
so when you're talking about this really, I mean, I feel sort of a very warm, fuzzy feeling inside, thinking, gosh, you know, we're on the right track.
You are definitely on the right track. And, you know, there are really good things going on, recognising that Age UK in different parts of the country does similar things as well. And we need more and more of it. You need a very broad brush offer. I love the Let's Dance campaign that
Yes.
Angela Rippon set up last year, and it's about to be relaunched for next year as well. Or not, you know, it's continuing
yeah.
because dancing, oh, fantastic.
Yeah,
You know, it hits absolutely everything. It's so good for your cognitive function as well, because you have to concentrate.
yeah.
And it's very good fun. And you've got the music and you've got movement. I mean, it could not be better. So, yeah, no, well, hats off to Walfinch for doing that, because that is a real contribution.
No,
you know,
that's
that makes a difference.
really exciting as you hear that. But so the other part of it is thinking about them. So we've got the older community there.
Yep.
And then we've got people in their sort of late 30s, early 40s. So if I think about myself, I'm 38 years
Yes.
old. Me and my wife are similar ages. I'm too polite to say how old my wife is. And you know, we both exercise,
Yeah.
and my
Yeah.
wife makes sure that I don't have too many chocolate biscuits because you know, I have a sweet tooth and so on. But what would be your advice to people in our situation? So we're busy, we've got young children, but we are interested in well-being.
Yeah.
And actually, you know, I've always been interested in exercise and muscle mass because I was a bit of a sort of gym fan from the age of sort of 15 or whatever. But I'm more interested in wellness as opposed to aesthetics now.
Yes.
And building muscle mass for the benefit of later life.
Yeah.
But so what would be your advice to people in my situation and my wife's situation, thinking about, you know, women in their 40s and 50s going through menopause and so on?
Again, I would try and make it all something that you enjoy, because it's going to become a habit. And this is about forming good habits that you then maintain forever. So it's not beating yourself up about it. It's not saying, oh, I must go to the gym and, you know, and I've got to do this amount of exercise and whatever. Try and make it something that you enjoy, that's your routine. You know, if you're an amazing person, you can get out of bed and run 5 kilometres in the dark, fantastic, and you're going to get a buzz from that. If that's not your thing, find something that is, and build it in a way that's sustainable with your family life as well. So that would be one piece of advice. This is not about making any of this a burden or something that you have to do. It's something that you enjoy doing, are proud of doing, and so on. And the same goes for the eating habits. I mean, the great thing about eating now is that there is so much really good advice out there, and there are fabulous recipe books that have got, you know, great recipes for increasing your vegetable intake. You know, and this isn't about boiled cabbage anymore. There is so much that's easy to cook, quick to cook, and that you can batch cook and freeze and that sort of thing. So just embedding those habits that mean that your whole family are enjoying a slightly better diet. I mean, it's fascinating to watch. In the old days, I read a great thing about he was a builder in his 30s, and he went to his GP with fatigue and had the usual set of blood tests for people who are tired all the time, TAT. And he came out folate deficient, so he was deficient in folic acid. And his GP was about to write him a script for some folic acid, easy peasy, 1 tablet a day, 5 milligrams. And then he said to him, can I just check, what do you eat? And of course he ate what all the builders eat. And I see them on their way to work. They get out of the van at the garage and they fill up with petrol and they go into the shop and they buy a pile of crap, excuse me, but they buy a sausage roll and they buy a Ginster's pasty and they buy a bag of Monster Munch and an energy drink.
Sounds good to me.
And he realised when he went through his diet, this young man with a family was eating almost no vegetables. And he said to him, well, listen, you can take a tablet every day, it will work, but you could change your diet. And this young guy came back 12 weeks later, his hemoglobin had normalised, his folic acid levels were normal. He said, I feel so much better and I'm so happy because I've suddenly realised that my kids are eating better too. We've changed the way the whole family eats. So that recognition that our national diet, and as I say in the book, we all eat what our neighbours eat. That's one of the things. And my lovely daughter, who came back from Tesco's in our local town, and said, Mum, everybody's buying a chicken Kiev and a 4-pack of Thatchers. And then you think, okay, we need to change the national conversation about what we're eating. And it's hard work because people are short of money and they're short of time and they're exhausted at the end of a long day. And it is easy to buy a pizza and slap it in the oven. But actually, if we can just tweak that a little bit for people in their sort of younger adult life with families, that's going to make a huge difference.
It's really interesting what you were saying at the top of the conversation about the socioeconomic differences. I really think about that because if I think about my life right now, organic sort of meat and vegetables and whatever, they're damn expensive. My gym is expensive. I have a personal trainer so that I actually turn up at 6 a.m. It's expensive. All of these things cost a phenomenal amount of money.
Well, they do and they don't. What we need to recognise is that actually we spend a much smaller proportion of our budget on food than we did 50 years ago.
Is that right?
Much, much smaller. Yes, so actually food bills proportionately to a family's total pot are much lower than they were, notwithstanding the increases in food prices recently, which are pinching everybody because there are other demands on people's income. So it's not to say, you can all go out and buy a slab of organic fillet and just get over it. That's not true. And that kind of meat is very expensive. But actually, cooking with a family, batch cooking dal,
which is how I grew up.
Which how you grew up. And my husband absolutely loves cooking good Indian food, which is lucky me. And but that kind of change does make a huge difference, and it doesn't have to be time consuming, and it can be incredibly good value as well. Yes, you have to factor in the amount of energy, the energy prices of your gas or electricity and so on. So people have to be shrewd about it. But again, there are really good books of advice, good recipe books that take into account people working on a budget. The ones written for students are good, And, have a look at them, get them from the library, have a look and see if there's anything, or just look online and see if there's something that fits with your family life.
That is really interesting. If I think back to when I was a child and, I'm son of immigrant parents, and so A, budget was tight, but B, also, we ate what we ate.
Yes.
We didn't have
no choices. Yes.
Yes. My mum would, again, batch cook Indian food, which was largely, vegetables or beans and lentils and so on. And we would have that on a daily basis. And if I think about my vegetable intake growing up, it's probably much better on a daily basis.
Yes, I'm sure.
Because it was all mixed in. When I'm ending these podcasts, I usually ask, what is your one piece of advice to people that will help them, stretch the extra mile? So whether it's, more vegetables, more squats, or change of life, or whatever it might be. And how can someone thrive in their life? What would be your one piece of advice?
Golly, that is such a good question, Amrit. I'm feeling right under pressure now. I would say be proud of what you've done. If there are bridges that need mending, mend them now. If there are things that if you die tomorrow you would horribly regret, fix it now.
Yeah.
Grab the day, carpe diem, and be happy. If you can possibly find it in yourself to celebrate the good things, that's what I'd say.
Amazing. Thank you so much. And I really appreciate you taking time out of your busy schedule to come on and helping us all, learn and educate and cascade the message down. So,
Oh, thank you very much. It's been a great opportunity. Thank you.
Loved it. And thank you very much for tuning in to another episode of Walking with Walfinch. And I hope you enjoyed it and put some different things in your shopping basket. I certainly will be. Until next time.
Thank you very much,
See you
Amrit.
later.
Great stuff. Well done.
Thank you.